with that said, I will now hand over to Jess, who's going to talk about safeguarding in residential aged care.
All right. Hi, everyone. Like Emily said, my name is Jess. I am a PhD candidate at the University of the Sunshine Coast. Emily is one of my supervisors. And as Emily said, we sort of have this neat little group of us who are sort of looking at the sexual violence and abuse of older people from a sort of criminological or environmental criminological lens. So I'm going to just start with a little bit of context, as I'm sure a lot of you guys sort of know some of these facts, sorry. So as Emily said, the Royal Commission into Aged Care Quality and Safety identified about 50 people in residential aged care facilities are sexually abused each week. Research has also shown that about 60% of people involved in sexual violence and abuse instances had dementia, either as the victim or the perpetrator, or as both the victim and perpetrator. Victims are also more commonly females with cognitive impairments, and perpetrators were more commonly males. This reflects a lot of, sexual violence in other contexts, but it's also really important to consider for sort of the ageing population and the different dynamics of gender within ageing with cognitive impairments. And research also shows that sexual violence and abuse in residential aged care is perpetrated both by staff and volunteers as well as other residents. This is quite a tricky sort of, number to estimate. There is conflicting research about who it's sort of more commonly perpetrated by, a lot of sort of differing definitions in terms of what sexual violence and abuse is and how we label that when it does involve people with cognitive impairments. So why does abuse occur? Research by Drennan et al. Really sort of summarised this nicely and looked at some of the factors that contribute to abuse of older people in residential aged care. Now, this isn't specific to sexual violence and abuse, but a lot of these factors, are consistent across different types of abuse. So firstly, staffing factors, things like stress and burnout, attitudes, knowledge and understanding of abuse, how to identify abuse, how to report abuse, and a range of sort of staffing competencies and confidence levels. We then have facility-related factors, which are things like the physical environment, staffing levels, and sizes of facilities. And thirdly, we have resident-related factors, so things like cognitive impairments and care needs of residents. You can sort of see that, as Emily was talking about, if we're thinking about this idea of environmental criminology and situations, we have a combination of these things. We have staff, we have facilities, we have residents. And so we can look into sort of the intersection of all these different factors to really understand the social and environmental factors that we can address and consider when trying to prevent or prevent sexual violence and abuse and enhance safeguarding. We know factors that contribute to abuse occurring, but we don't know as much about factors which influence staff in their intervention and prevention of sexual violence and abuse. So we know some things, which I'll talk about in a second, but we don't really have this comprehensive understanding. So, like it says at the top, staff have a responsibility to protect older people from harm. That's a core component of what staff do and what aged care does, is to support older people, prevent harm, assist with sort of healthy ageing and people to live their lives as, well and safely as possible. In institutions, staff are uniquely situated to detect, identify, prevent, intervene abuse. They are there all the time. They have interactions with residents. They hear things from other staff. They hear things from other residents. It is a really, really sort of a unique, valuable role that staff play in crime prevention. We know, though, from research and from things like public inquiries like the Royal Commission that this isn't always the case. And in fact, historically, in a lot of cases, it hasn't been, or staff have sort of not played the role in preventing harm as well as we would like. There are many instances where staff have failed to protect older people from harm. So I've got some information from studies here on the slide as well, but studies reported that many staff observe cases of abuse, but very few cases of abuse are actually reported. And research also highlights some really concerning perspectives of staff around sexual violence and abuse. So this study by Moir noted that staff perceived abuse from co-residents to be a normal part of nursing home life, abuse from relatives to be a private affair, and abuse from direct care staff to be an unthinkable event. And that is really concerning. We know that attitudes play a role in how people act and behave, and we really need to sort of, I guess, work on this to make sure that we have sort of attitudes and we're breaking those types of myths that Emily was talking about of abuse not occurring or abuse not being harmful. So why don't staff intervene specifically in sexual violence and abuse? Like I said, we don't have sort of a really comprehensive idea, but we know some of the factors. So things like staffing, training, fear of consequences, and complexities in sort of substantiating allegations or believing people with dementia. So we know, again, like I said, staff are really important for preventing and intervening in sexual violence and abuse, but we really just need to understand more about why they do or don't intervene and how we can support staff and empower staff to intervene or to prevent sexual violence and abuse. Before we move on, I really want to flag something important as well. I really want to make it clear that this research doesn't represent everyone. You know, these quotes are quite confronting, I guess. And I know that, you know, majority of aged care staff are there to protect people, are there to do their job. They care about older people. But, you know, we do have some instances where people do have really sort of harmful attitudes. And we sort of have some systemic attitudes and concerns around ageism, around perceptions of seriousness and around harm that does occur that really do influence it. So, like, it's really important for me to note that this research isn't about criticising people. It's about trying to understand and support staff working in aged care and empower those staff so that we can better enhance prevention and intervention in sexual violence and abuse of older people. So I'm going to go a little bit into some more theory stuff, just very briefly. These concepts that I talk about in terms of guardianship come from environmental criminology. And as Emily said, environmental criminology is really focusing on how crime occurs and what we can do in the environment to disrupt or prevent crime. And so one technique that we can use is staff. Before we move on, I also want to focus on this term of guardians or guardianship for a minute, as I'm sure many of you in sort of the aged care sector are familiar with the term guardianship in the legal sense. This is talking about the term of guardianship in the criminological sense. So when I'm talking about guardianship, and when we talk about it in our environmental criminology, we're talking about any person who may notice and intervene in potential crime. So we're talking about sort of a safeguarding figure, someone who is there, someone who can play a role to prevent and intervene in crime. And we know from research across a broad range of contexts of sexual violence and abuse that guardians, a person nearby, a capable sort of safeguarding figure are really effective for preventing, intervening and disrupting crime. So an Australian colleague named Danielle Ronald really sort of revitalised some of this research around guardianship. And so I'm going to present this model to you, this idea of guardianship in action. Now, this focuses on three core dimensions. The first is availability. A guardian needs to be available. They need to be present. They need to be there. Secondly is supervision. So for a guardian to for a guardian to intervene, they must first be willing to supervise and they must be capable of supervision. So they need to be able to physically see what's going on, as well as be able to detect and identify certain behaviours or signs as concerning. Lastly is intervention. This is arguably the most complex and sort of critical dimension of guardianship. So to intervene effectively, a guardian must be willing to intervene and must be capable of intervention. So in the context of residential aged care and sexual violence and abuse, This model lends a really valuable lens to sort of examine and understand staff decision-making and behaviour, and how we can sort of understand how crime occurs because of staff actions, or that staff actions may contribute to, and how we can therefore enhance staff actions and behaviours to prevent and disrupt crime. So getting into some of my research. So my first study was a document analysis of Royal Commission documents, so from the Royal Commission into aged care quality and safety. I analysed volumes 2, 4 and 5 of the final report. And I did so using the model of guardianship that I just discussed. So what were factors that influenced availability, supervision and intervention? And ultimately found that guardianship was influenced by a range of individual factors, so factors related to the staff person themselves, as well as situational and contextual factors of the environment surrounding them and the context in which they were operating. Factors included, so individual factors included things like attitudes, confidence in concerns, concerns for consequences, perceptions of responsibility, and then contextual factors were a lot more evident in the text, partially due to the nature of the text. So because the Royal Commission was into the aged care sector broadly, a lot more of the factors that came out were about the context. But this was things like the physical environment, organisational culture, the governance of the sector, organisational policies and procedures, information sharing practices, and staffing levels, training and competencies. So this was sort of, I guess, one of the first research studies really trying to understand a comprehensive view of the factors influencing safeguarding against sexual violence and abuse in residential aged care. So this showed us, you know, we do need a lot more research. There are things to understand here. We need to unpack this more. So that brings me to my next sort of piece of research, which was about the perspectives of aged care staff. And this was really important to me. I always use analogies from when I worked at Baskin-Robbins about, you know, higher up management levels making decisions, and that influenced us. You know, that's obviously a very small, minor, low harm sort of comparison, but within aged care, within schools, within universities, within businesses, we have a lot of these processes that are decided, but actually ultimately influence the people on the ground. So I conducted interviews with aged care staff. At the moment, I've conducted 7 interviews. These were with staff in various levels and roles. So personal carers, permanent staff, agency staff, clinical coordinators, management staff, pastoral care staff, etc. Conducted a reflexive thematic analysis, so qualitative, looking at what people were saying and what that really meant, and focusing in on these 2 questions. So firstly, what do staff think are challenges for detecting, identifying and responding to sexual violence and abuse? And secondly, what do staff think we can do to enhance safeguarding? It was really important to me that this research was reflecting the people who are actually working in these situations and contexts. So this is just a very sort of broad overview. There is so much data to work with, and I'm really grateful to those participants and those staff for sharing their perspectives. So yes, very sort of broad for this presentation, but there is a lot of sort of complexities and nuances to work through that also really differed depending on the role of that staff member. So first of all, some of the contextual challenges. Firstly, organisational practices. So things like staffing levels, staffing consistency, staffing competencies, things like training, policies and procedures, and organisational culture. I've also included some participant quotes to highlight some of these sentiments throughout as well. So this one, the supervision won't be there 24/7, right? I think the vulnerability I perceive would be around the after hours or the weekends where, you know, senior nurses are not there, your admin staff are not there. That's probably where that gap would remain. So that's reflecting, you know, some of those challenges with supervision, with staffing, with role demands, with organisational policies and procedures, and how we manage that to really sort of, or where those gaps remain in terms of being able to supervise residents effectively. Next, reporting processes. A lot of participants talked about these reporting processes being complex and really time intensive. So one person said, they're the most useless forms ever. None of us like filling them in because they're just so convoluted and take so long. If they were simpler, it'd just make life easier because they do take hours. And the time factor could be an issue with that just because who has hours? So again, when we're thinking about staffing, when we're thinking about the aged care context, it's not just the staffing numbers, but also the demands on those staff and then the additional demands of having to go through these reporting processes. Lastly, the physical environment. So there was a really complex intersection between privacy and safety of residents. So one participant stated, if you revise their homes to make it like a clinical setting so it suits our need, it will remove their sense of dignity and privacy. So there's this really hard intersection between how do we sort of safeguard and manage people. And I didn't have it in here, but another participant said, it's really hard to safeguard people because we are not a prison. We're an aged care home where people's homes, we're there for safety, we're there for support, for healthcare. And so it's this really difficult intersection to manage for staff. Some of the individual challenges, things like knowledge and understanding. So the capability of staff to identify and report concerns. And then participants really highlighted this these complexities around consent and cognitive impairments. There were differences in sort of perceptions of seriousness. So what do you understand? If you don't perceive a certain behaviour to be serious, that's really going to impact how you respond to that behaviour. Things like resident boundaries. So what an older person perceives as to be sort of breaching their boundaries or in the bounds of what they perceive to not be okay or safe behaviour differs between residents as well. And then we also have aspects of cultural differences. And this was acknowledged a lot, particularly in talking about the diversity of the workforce. We have a really, really diverse workforce, and that has so much value, but it also does provide complexities in ensuring sort of staff understand and know the sort of context that they're working in and the behaviours of the residents and what is, acceptable or inappropriate behaviour in our aged care context. We also had uncertainty of concerns. So communication barriers with residents. As we all know, there are a very high portion of residents in aged care who have cognitive or physical impairments, and that can impact communication. Things like lack of proof or challenges with substantiating claims, and uncertainty of concerns from staff due to cognitive impairments. So just a few quotes. So first of all, some people don't see the seriousness in certain things. This person was talking about, the spectrum of behaviours that fall under sexual violence and abuse, but really differ, between somebody doesn't like to be showered by a certain person, or someone said something that they perceived that they were upset by, all the way to, some really severe sort of physical sexual harm. Another person said, but when that person has cognitive impairment, that question of whether it happened or not, is that delusion? Is that hallucinations? Or, it didn't really happen, but it was misinterpreted. That can usually be a barrier. Thirdly, that same participant also said, if you don't really know and you already have 10,000 things to do, there's an urge to just be like, look, I'll just let it slip. Someone's going to pick it up anyway. I'm just going to let it slip. A couple more sort of individual challenges as well. Concern for consequences. So there was a really, really high level amongst participants of concern for consequences for employment, as well as social consequences. There was also this sort of level of care where care seems to play a really big role or levels of care seems to play a really big role in sort of what effort people are willing to go to, report things or intervene. So there are things like perceptions of responsibility and perceived effort that really played a role there. So a couple of quotes to really highlight this. Someone said, I think people just keep quiet. They're like, you know what? I'll just do my job and go home and earn my money and pay my bills and just look after my family. I don't want trouble with work. I'm good. Again, that really highlights, some of the concerns around consequences for employment and for, that sort of effort or level of, I guess, care or the level of importance of intervention and what that means or what that compromises for the staff member. Another person then said, there's a bit of a workplace culture, someone new coming in, you don't want to ruffle feathers, you don't want to alert someone to things that are going wrong or not being done properly, because then, people might treat you differently or not welcome you. So again, really highlighting these social consequences. And some of the staff talked about things like, you work in a buddy system or you have to sort of have huddles with these staff. And when people don't trust you, that also makes your job really, really difficult. So like I said, this is just a really, really broad sort of overview of some of the factors that staff identified as challenges. Like I said, there's a lot of nuance and complexities, but these really highlight some of, I guess, the top level issues and challenges for staff. So again, it was really important, one, to understand staff perspectives of challenges, but also staff perspectives of what we can do to enhance safeguarding. And participants discussed a range of strategies. Before I cover the strategies, I want to highlight this quote. So one participant said, you can have the best systems in the world, but unless you've got the right people and the right amount of them that are supported, they're going to be challenged to be actually able to use the system as it's intended. So whilst staff did identify that there were challenges with the system, there are also a lot of challenges in trying to ensure that we have the support and the capabilities for staff to enact and operate in that system. So this is sort of, again, a top-level summary of some of the strategies to enhance safeguarding. So firstly, aiding supervision. A lot of the participants talked about the value of CCTV in common or public areas, potentially extending that if residents wanted CCTV in their private rooms. But staff really highlighted that, one, this would provide evidence for the movements of staff or residents in cases of allegations or uncertainty of concerns. So there's a lot of talk about, certainty of concerns and not having proof and not having evidence and just not being able to supervise everything. So participants really talked about the value of CCTV in providing some of that evidence and proof. It can also aid in surveillance when there are limited staffing numbers. So for example, at night, if you can have sort of a monitor that has screens that show you, various areas of the facility. Participants also noted things like sensors in bedroom doorways and doors with locks. However, this also obviously poses some additional safety and privacy concerns, but really highlighting the need for assistance with surveillance and some assistance with, I guess, proof and supporting staff or organisations to really investigate and have some, tangible evidence of movements, I guess. Participants also focused a lot on the reporting processes. So they talked about reporting processes, we should reduce the complexities, and ideally this would involve consistent processes across aged care providers. We have the serious incident response scheme, but the systems, the sort of flow on to different management roles is different across different institutions. We should try to reduce documentation burden on staff. We also, participants really stressed that reporting should be anonymous or as confidential as possible. I don't have the quote up here, but one participant said that somehow everyone always knows. You can trace it back to who was on shift, you can sort of figure it out, people talk, and that really poses a lot of challenges and a lot of barriers to people feeling comfortable reporting. Organisations as well, participants said, should really build trust with staff by sort of communicating and updating them on those sort of investigations or what they are doing in response to concerns. Participants really talked about how, people can report things, but then are like, well, I don't know what's happening with it. Are management even doing anything? What's the point? Participants also discussed training. So training should be based on real life scenarios and needs to really focus on complex grey areas in detecting and identifying and responding to concerns. So things like in in cases of cognitive impairment, especially in cases when you have older people who were in a relationship or married before entering aged care, or when there are relationships that come about in aged care, and some of the complexities as well with managing or responding to families in those instances. Training should address appropriate and inappropriate behaviours and boundaries, and should also navigate some of the complexities around intimate activities. So for example, bathing, how to appropriately sort of communicate with residents, and sort of have a more open, I guess, consent dialogue. So I'm just going to do this, or I just need to wash you there, or are you right if I start with this process? Training as well needs to acknowledge and accommodate for a culturally diverse workforce, and this was really emphasised by participants as well. Lastly, participants really focused on the importance of empowering staff through organisational culture. So things like management being open and willing to discuss concerns, management staff getting to know staff, being familiar with the staff on the ground, and providing a sense of support, demonstrating that they value their staff as well. And one participant noted that if you show that you value your staff, you're also showing that you're valuing older people by investing and caring for that workforce. Participants really highlighted the importance of a culture that is sort of not about getting people in trouble, but about trying to help and support each other, and to support older people and do your jobs as best as possible, and a need to sort of shift the attitudes around reporting. I do have one final quote. One participant said, "I think a lot of people doing the design of what needs to be implemented, they're not end users. They've got absolutely zero perspective on what they're imposing and how it actually looks in reality for the people delivering the care. I think the focus needs to be on the end user." And I'm really hoping that, this research contributes to some of that understanding. I know a lot of these things might seem really obvious, and that a lot of people, know these things in practice, but hopefully having some of that research, having some of that evidence base, and really highlighting staff perspectives can help us to sort of implement these things in the real world context. So what does it all mean? Firstly, I've discussed a lot of contextual and individual factors. We need to address both. We need to address the individual, we need to address the situations and the context. We need to focus more on navigating real-world situations that are really complex, particularly in aged care, particularly when we've got an aging population, particularly when, as we're getting older and we're increasing the lifespan, we do have more things like increased cognitive impairments, complex relationships with other residents, family, staff, all of these things. We really need to sort of not be looking at a picturesque or idyllic sort of context. We really need to understand and deal with the real context. Lastly, we need to incorporate staff perspectives about safeguarding. They are in the situations, they are in the context, in the facilities. They know what works, they know what doesn't work. And we really need to provide more platforms to support people to share their perspectives and to inform us of what actually is going to work, so that we can implement those things, so that we can enhance safeguarding and support staff to prevent and intervene in sexual violence and abuse of older people in residential aged care. So that is all from me. I did want to flag as well that I am in the final stages of data collection. So if you do work in aged care, I am still recruiting for interviews. If you would like to participate or you would like some more information, that QR code will lead you to the interview sign-up page. I just want to acknowledge again, I'm really grateful for all the staff who have shared their perspectives with me. And hopefully this research can go out and, help support staff in turn. Perfect. I will pass back to Emily now. Thank you very much, everyone.